Hello again, MBA students. Dr. Ron Kapp here with week 3 of Management 5420 Antioch. Healthcare sector is a complex system. This week I will try to be a little more brief. I know we ran over a little long last time, and I'm going to try and cover the hospital sector this week. It turns out it's a very big sector, but I'll do my best to shorten it down a little bit. As you know, hospitals really are the main economic driver of everything that's happening in the healthcare sector. Everyone knows hospitals. We see what they're building, bigger and bigger facilities. And that is where the money really is being generated in this year. Hospitals, as you know, really represent healthcare. It's the best of American medicine. It's where the talented doctors work. Not to say that talented doctors don't work in offices and other places, but we think of hospitals as the most talented doctors. We do know that the most technologically advanced products are available in hospitals. The newest robots, the newest electronic equipment, all the genetic testing that we do, all started in hospitals. When we think of a hospital, we think of that's where you go when you're sick. That's where your doctor sends you when you're sick. That's where you go for operations. Really, the heart of the hospital is the ICU when people contemplate what is a hospital. It's the intensive care unit. Some people think of it, well, that's where babies are born. I think of it as a little bit differently. I'm an emergency room doctor, so I think of it as an emergency room. And I think of it also as a place where we go to die, notwithstanding the fact that we do have hospice and home places where people do die at home. Most people do die in the hospital, in fact. I wanted to show this slide because it really does illustrate the massiveness, the complexity of our entire system. We have over 6,000 hospitals in the United States. Most of those, 5,100, are community hospitals where the average person goes. And when you break it down, you have the not-for-profit community, the for-profit community, and then some government community. I think the point of this slide is that with 6,000 hospitals, that's going to be generating a lot of economic return and care for a lot of people. In fact, the number of people we do care for is truly a phenomenal number. It's 36 million. This was 2021 data from the American Heart Association and the American Hospital Association, and probably the JAMA also for American Medical Association. You can buy this AHA hospital statistic report for $325 if you want, but it does show that we've had 36 million hospital admissions for patient care and generating over $1 trillion in expenses for all those different hospitals. So that alone shows you the size of the system we're talking about here. It's quite phenomenal, really. I like this map because it does show where the community hospitals are located. This has the little over 5,100 community hospitals throughout the country, most on the East Coast, quite a few in California, and then leaves the West where there's less population, of course, less hospitals. It's all population driven. I just thought it was a very interesting slide to think where you may want to work in the future. Now, we're getting to the heart of what hospitals really cost us. In fact, they generate 40 to 50% of total health care costs. In other words, that economic pie is being divided up into hospital care, 40 to 50%. And sadly, that cost has increased quite dramatically. They had a 149% increase from 1997 to 2012. And what is most interesting, I thought, is that 10 to 15% of that revenue goes directly to billing and collections. That's a large amount of revenue going to collect what they're owed by patients or insurance companies. It is expensive to stay in the U.S. hospital now, as you probably are aware. As you can recall, the first hospital in Dallas was $5 a day. Now we're up to approximately $2,000 to $2,600, even to $3,200 a day for what hospitals cost us. This is very geographically dependent because places like California, where cost of living is higher, it's going to be much more expensive to have a patient inpatient in the hospital versus a much lower geographic location. It's also dependent on the specialty. Neurosurgical hospitals generate and cost much more to stay in a neurosurgical facility compared to a general hospital. So it all depends on geography and specialty. But this gives you an idea that it's not cheap anymore. It costs a lot of money for us to spend some time in the hospital. And as you can realize, compared to how it started in Dallas, we were charged by the week. Today, it has changed such that hospitals now charge the patient or the insurance company for each service and each encounter. Everything is documented at what you are giving the patient. You've heard stories where a Tylenol pill costs $5 or $10. This is true. We do charge for each service and each encounter. It's no longer what it used to be. Here's the key slide. Medicare is driving this entire process. From 1967 to 1983, the Medicare payment to hospitals in America ballooned from $3 billion to $37 billion in that time frame, and it's significantly more now. Because of that, because Medicare is driving this process, and as you learned last week, Medicare is one of the more efficient operated entities for administrative costs. What we invented was called the DRG. That's something you have to know about. Diagnosis-related groups, or diagnostic-related groups, depending how you look at it. The DRG is basically bundled payments. Here's how it works. If you have pneumonia, that's your disease. That's your diagnostic-related group. You have pneumonia. Therefore, Medicare says, we will give you a fixed set amount to treat that patient's pneumonia when you admit him to the hospital. And every disease process has a DRG affiliated with it. The hospital and the physician are then required to take care of the patient. If they take care of the patient and it costs less, the hospital can keep that money. If it costs more, yes, the hospital has to pay for it themselves. And that was invented in the mid-1980s. I remember it well, and it still is what drives medicine today. Bundled payments with DRGs. That is a take-home point. If you go into the healthcare business, you want to know about DRGs and diagnosis-related groupings. Now that did help back in the 1980s. It helped quite a bit, in fact, but not really enough. Prices continued to increase. Insurance premiums continued to increase, increasing easily 25% every year for insurance premiums and everything we're doing. So in the 1990s, the HMO, the Health Maintenance Organization, was invented. It became very popular. Had been invented long ago, back in the 1920s, in fact. But the HMOs became very popular. It was a fixed payment per patient per month. Everybody was enrolling these. One of the largest here in California is the Kaiser system, and it's very well run, and they did manage to control their costs. Unfortunately, it wasn't enough, but it did help. And today, in the 21st century, HMOs have become less popular than when they were back in the 90s. So that was a brief history of the origin of today's healthcare management system and what it really led to, what many people call the medical arms race. And it really got out of control. It's still out of control. But it was so out of control in 1974 that the U.S. Congress passed a law requiring state health planning agencies to grant approval before hospitals could expand or build new facilities, because it was a medical arms race. Sadly, in 1987, that federal law was rescinded, and the arms race again accelerated significantly and continues to this day, as you'll hear in a few minutes. What has transpired is that Hospital reimbursement has become a strategic puzzle. It's an economic nightmare, really. Now, Medicare assigns to each hospital a specific overall cost to charge ratio. Once that is created, the hospital then creates a master price list called a charge master, and that then drives what they charge insurance companies or patients. Now, it's very hard to get these charge masters. You cannot ask a hospital, show me your charge master. They will not show you. And they also, as you'll learn in the insurance module soon, that different insurance plans get different discounts and reimbursed rates from different hospitals depending on negotiations. Who's doing the negotiating? The strategic billing companies, the consultants that are hired. Many of them are MBAs. One of the biggest is Deloitte. Everyone's heard of Deloitte. Deloitte has had revenues of nearly $50 billion in 2020. That's not all medical. They consult for many different things, but a large portion of it is Deloitte consulting for hospitals to solve this strategic puzzle. What was created next was called the RVU, called Relative Value Units. This is a measure of productivity that is used to determine medical billing. We give it a scale from 1 to 5, 1 being low level, level 5 being high level. When it's high level, of course, you charge more money. The productivity bonuses are then created so that when you have high productivity, you can get more money. In fact, in 2015, 71% of physician practices were supplemented with a salary bonus for productivity that was above and beyond what they were expecting. And of course, what would naturally happen is RVU billing led directly to what's called coding creep. In other words, we upcode to a higher level. For example, a patient comes in and perhaps they initially qualify as a level 1 or 2, which is low level. The coding can then be manipulated and massaged so it becomes a level 3, 4, and sometimes even a level 5. That generates much more money. Who wouldn't do that? Great business model. Upcoding then led directly to what's called facility fee charges, and they're linked to the RVU levels of service. Now, very few other organizations or companies have facility fee charges. The only one I can think of is a resort fee. If you go to a 5-star resort, they often charge you a $20 or $30 resort fee. But normally, a company does not do that. You do not go to the movie theater and pay a facility fee for sitting in the chair, or go to a restaurant and pay a facility fee for using the table. Hospitals, on the other hand, use and charge a facility fee charge based on the RVU level of service. It's a good business model, and that's how it's developed. So, just to summarize briefly, the historical trend is basically make money or die. I've worked in, as you know, many hospital systems, several of which have closed due to economic problems. They just cannot survive in today's world. But what's happened was what we just reviewed. There was a charge for individual services. Then the DRG and bundled payments came along in the 1980s. Then the HMOs became very popular in the 1990s. They did try to pass a fair number of federal laws to protect hospitals and patients and insurance companies. But what really drives the process is that all medicine is state regulated. My medical license is from a specific state, it's not from the federal government. And then, of course, the consultants like Deloitte came in, and then we had RVU and upcoding that came along more recently. And the goal was either make money, whether you're a for-profit facility or a non-profit facility, because if you don't make money, your facility will close. And as I just mentioned, that happens often. Fortunately, many more ways were developed for hospitals to financially survive and continue. One way was to close the department that is not making money. Hospitals are allowed to close an emergency room. Yes, they're allowed to close labor and delivery, dialysis units, drug treatment centers, clinics if they're in a poor neighborhood. They close the departments that are not making money. Then the second thing they did was they started outsourcing services. I work as an emergency room doctor. I don't work for a hospital. I work for a contract management group that contracts with the hospital. So they contracted and outsourced the resources of the emergency room where I can work. We've done the same thing with radiology departments. We have the hospitalist, who is the internist or internal medicine specialist, who takes care of, nowadays, most of the inpatients. And we've even started outsourcing some surgical services. Same thing. The other way that hospitals came up with these ideas was to spin off a business. For example, pain clinics typically do not make a good profit. Hospitals spun them off as a separate entity. They have done the same thing with dialysis centers. DeVita, country's biggest dialysis center, used to be always in a hospital. It's now outsourced, spun off as a separate business. We've done that with radiology. We've done it with sleep units. I think you can see with just this quick and brief review of what hospitals are doing that this is why medicine really needs and uses the MBA consultants, because it is a very complex environment. And that's the point of this brief PowerPoint this week. It is so complex that the MBA needs to start understanding some of these things. There is another way that money maker that hospitals use. It's quite innovative, in fact. That one is called the observation status. Observation status. Many years ago when I started in this business, we did not know if someone was having a heart attack or not. We suspected, we would not sure. We would then place them into an observation unit. Or maybe they were potentially had appendicitis and we weren't sure. We would place them in an observation unit or room. Maybe certain infections. We weren't sure if we were going to admit to the hospital. We put them in observation status for medical reasons. We would observe them, see how they do. And then if they needed admission, we would subsequently admit or discharge, send home. But now we do it for financial reasons. Here's why. Medicare, once again the driver, pays a fixed bundled rate for admitted patients. So if I'm admitted to the hospital for appendicitis, Medicare pays a fixed amount for the surgery to take out my appendix. However, if something goes wrong with any of these admitted patients and they bounce back, in other words, they return for another problem, within 30 days, the hospital gets a readmission penalty. They're penalized for a patient getting sick again. Now, it is a good way to improve medical quality and care, so I can't say it's a terribly bad thing, but it's something that we do for financial reasons. And here's why. Number two, Medicare has no limits for patients in observation status. No limits meaning money. You can charge more. You can say, oh, the patient has been in observation status. And we have what's called the 2 midnight rule, where we look at what time did they enter the observation room and what time did they leave. It's very complex. So I think what the MBA needs to understand and remember is there are different ways of manipulating the system and different ways that we can either admit or observe patients. And it's a puzzle. It's a true economic puzzle. And the more you know, the better. Of course, so that you as the driver and the leader of the hospital system in the future, if you are not already, will have some foundation of what this is all about. Speaking of drivers of money, it's the magic of cheap labor. Now you'll recall in week 2 I talked about physicians' starring role. Well, yes, we do work in hospitals. And we do play that starring role. However, it's the cheap labor that really is the critical factor here for you to understand. In the pre-1940 areas, before World War II, hospitals paid resident doctors a stipend by building their pay cost, their salary, into the patient charge. However, after World War II, the GI Bill changed that, and we began subsidizing physician training through the GI Bill. A small change, but it made a drastic difference. The major change was in 1965 when President Johnson signed into law Medicare. At that time, it was mandated that federal and state funds should cover physician training. Remember those residents, years 3 to 7? Those residents, they would subsidize that training as a public service. Now, over $16 billion was transferred from Medicare to our various residency programs in the year 2015, paid directly to the hospitals. I think maybe one of the young MBA students will figure out how much we paid in 2021. These numbers are sometimes difficult to get. Those are our tax dollars, however. And then it changed again in 1997 with the Balanced Budget Act, which capped the total number of Medicare-funded residents. We haven't lived up to that Balanced Budget Act of 1997, but it was still an attempt to try and control some of the resident physician training programs. And then, of course, in 2015, President Barack Obama, his budget called for cuts in resident physician training of almost $15 billion over 10 years. Well, yes, obviously it was never passed by Congress because, as we now know from week 1, the AMA and the hospital associations are the largest lobbyist group in Washington, D.C., so that was never consummated to say, let's decrease resident training. Now, I'm giving the impression here that these are all bad things, I think. It's not true. These are some good things also. And just because we're calling for cuts, it's a very hotly debated topic out in the real world when you talk to a residency program director or talk to resident physicians who are making $10, $20 per hour at most. That they don't want their pay cut. They don't want their number of residents cut. We did several years back decrease the number of resident hours that were required and gave them more rest, which is a good thing to do. So this is a very hotly debated topic. But nonetheless, overall, it is cheap labor, and these residents are being taken advantage of. Speaking of being taken advantage of for money, Medicare, as I just said, pays for resident physicians as that public service. Average federal support for a resident approximates $100,000. Goes directly to the hospital and the residency program. Now, a resident is a physician. They've graduated medical school. They're an MD. Residency lasts, as I said last week, anywhere from 3 to 7 years. The average resident generates every year for that hospital upwards of $200,000 in billable services because they're seeing patients. They're doing surgery. It varies on the hospital, varies on the geography, varies on the specialty, but overall, when you look at the American Hospital Association data, it's about $200,000, $230,000 a year. The typical resident salary is $50,000 to $80,000 a year. Now, I'm going to put it in red. Is this a great business model or what? It really is. Is it any wonder why President Obama's 2015 budget cuts were never passed by Congress? We capped their hours. We've increased the number of residents. We've even brought in international medical graduates. And the system continues to get bigger and bigger and bigger. Now, this, too, is a very debatable issue, but it's something that the MBA student does need to know about because if you're working in hospital systems, you will run into these types of issues. What's really changing in today's world is that hospitals are becoming 5-star resorts. We have concierge medicine. We have parking. We have lobbies of marble and crystal chandeliers. And we have private rooms. And we have, most importantly, Press Ganey surveys. Now, Press Ganey was an anthropologist, and he wanted to see how hospitals were doing, so he devised a patient survey. He would ask the patient, how did you like the hospital? Did you enjoy the hospital? Was your doctor nice? Was the staff nice? Those kinds of things. And greater than 50% of all hospitals in our country use Press Ganey surveys. Here's why. Medicare pays a bonus to hospitals for good patient surveys. Did you get that? Good patient surveys. They're not so interested in quality care. They want a good patient survey. Now, as you can tell, as a practicing physician, I'm not keen on patient surveys. I want to heal the patient. However, as an MBA in the C-suite, patient surveys mean a lot to you because you are getting some extra money into your hospital system. So it's something that you need to know about. Press Ganey surveys. There are a variety of other surveys, but this is the most commonly used and the most important. While they're 5-star resorts, 2/3 of all hospitals are nonprofit. They get tax benefits. Everyone knows what a nonprofit 501c3 is, but the tax benefits are phenomenal, and again, a highly debated area. The CEO bonus is often based not on patient care, but on the finances, on the quality of their surveys, on their profit that they're generating, the number of admissions, and their net funds. So what I'm trying to get at here is there's a true dichotomy between caring for the patient as a provider and the business of medicine. It's the practice of medicine versus the business of medicine. We talked about that in week 1 of this course, and it's still coming up over and over. I'm going to keep bringing this up over and over. Now, hospitals have that nonprofit status. If you want to study the hospital, you get Schedule H on Form 990 from the IRS, and you can see what they're doing. And this is good. Hospitals have a role and a mandate to provide some community care. However, I'm going to go out on a limb here and say that they're taking advantage of this. As an example, the Mayo Clinic is a nonprofit. Several years back, they signed a joint venture with Hill House Capital Group, which is run by Li Zhang, who's a billionaire in China. And they want to build they did build a medical center in China called Huimei Healthcare. But it's affiliated with Mayo Clinic, which is nonprofit. But the medical center in China is for-profit. More than 30 other nonprofit hospital systems are doing the same thing of a for-profit joint venture around the world. So that's where the issue of economics gets very debatable. Here we have a nonprofit system in the United States building hospitals around the world in for-profit environments. And that's something we can talk about during the discussion if you want, or you can research it on your own, but it's quite a fascinating combination of medicine as a business and medicine as a practice to heal people. So week 3 in review, I think I was briefer this week. The complexity of your medical system here in America is becoming more clear. As you see that we outlined a little bit about physicians last week, hospitals this week. Next week we'll continue on with pharmacy and insurances. Medicare truly does drive the process. HMOs, DRGs, RVUs, upcoding are some of the different factors we use for making money in this system. I think the key point is nonprofits are competing in the free market as a business entity also, even though they have nonprofit status and tax benefits. I do believe in hospitals because they provide the structure for the scientific and technological advances that are happening. A lot of research, in fact, is done in hospitals. Our government does support a lot of that research. And I think overall, your take home here, as we've unraveled a little bit about the hospital system, is the MBA graduate has opportunity to manage this entire system. And the more you know, the better. Your management can then drive improvement and innovation for the future. So that's the end of week 3. I hope that gave you a little more understanding of the hospital system in America. My name is Ron Kapp. This is Management 5420 at Antioch University. And we're done for the week. I'll go on for your readings and your videos on the internet. Thank you. Have a great week.